Can learning about the neuroscience of pain help patients with chronic lower back pain? Let's take a look at this randomized trial and see what they found. The study looked at an intervention called pain reprocessing therapy, which is basically a form of psychological management that teaches the patient to understand how chronic pain can emerge and how chronic pain may actually be coming more from central structures like your brain and your spinal cord than the actual location of pain in itself. The cornerstone of pain reprocessing therapy is teaching patients that the pain that they're experiencing when they're chronic is not likely coming from an injured or damaged body part, and it's likely coming from the brain or the central nervous system sending alarms inappropriately in a response to an area that is trying to protect. The cornerstone of pain reprocessing therapy is this idea that chronic pain likely comes from the brain and the spinal cord and less likely from the injured or damaged body parts where you're actually feeling the pain itself. Meaning that if you strained your back or you injured a disc or something along those lines, the normal healing time for those tissues is usually weeks to months. And if people are having pain beyond weeks and months at a time, then it is likely coming from your central nervous system as opposed to the damaged tissue itself. The problem is, when people have an injury, they become a little bit fearful of movement, and that fear of movement is likely going to make people start to trigger pain signals in response to the fear as opposed to the actual damage to the body itself. Pain reprocessing therapy tries to flip that by teaching people that your injured body part is okay, and even if you feel the pain that is coming from there, it is likely coming from your brain and central nervous system, so you're not going to do more damage to yourself by moving and experiencing some of these areas that are painful, but are actually pushing through it and understanding that that body part isn't injured, that you may actually have a meaningful ability to reduce pain. So the study took patients with chronic lower back pain and they randomized them into the pain reprocessing therapy. They also randomized people into an open label placebo, meaning people got a saline injection into their back, but they knew that that injection was saline when they got information about the nature of placebos and how people can still get a pain relieving effect even when they know it's a placebo. And they also got randomized into getting the usual care, so whatever pain care that they were getting before, they were told to stick with that during the study duration. So let's look at some of the results. So here's a chart that looked at the percent change in pain intensity from baseline to post-treatment. You can see that the pain reprocessing treatment group had a significant decrease in the amount of pain that we're feeling on average when you compare the placebo group and the usual care group. Their numbers decreased a little bit, but they're fairly similar in comparison. When we look at the number of patients that reported being pain-free or nearly pain-free, almost 66% of the pain reprocessing patients reported to be nearly pain-free, while the placebo group and the usual care group had a much smaller amount of those patients that reported being pain-free. And we look at the pain intensity over time, you can see on this bottom chart is the pain reprocessing therapy where their pain intensity was slightly above a 1 out of 10. And where the other groups stayed pretty consistent right around the 3, and this effect seemed to stay in place from 1 month to 3 months all the way up to 1 year after treatment. So what we see is that usual care and placebo were pretty similar, but pain reprocessing therapy had a pretty significant improvement. So just from the simple idea that you could sit and educate a patient over the course of 8 weeks about the nature of pain and that it's coming from the brain and not coming from the body can drastically improve the status of someone's chronic lower back pain. Now, the biggest drawback of the study is that it's open label. The intervention group knew that they were getting the studied intervention, the placebo group knew that they were getting a placebo, and the usual care group knew that they were not getting the studied intervention. This is important because when you know that you are in an investigation and you are studying something that is new and interesting, if you know that you're not in the group that is getting the interesting thing, then that might have an impact on how the placebo is affecting that group. So this is one of the main drawbacks. Nonetheless, this is one of the things that we see in our office from a clinical experience standpoint, is that as soon as we start working with a patient that is in pain and we could tell the person that we have a high level of certainty that their pain is not coming from a damaged body part and that it is likely that their brain and central nervous system is causing the pain, just having a sense of a relief from